Welcome back to AI Snacks with Rom and Robbie, an AI literacy podcast where we make artificial intelligence and robotics digestible one bite at a time. And I'm your host, Anastasia, and today we are back with a guest who made a very deep impression on our listeners in our first conversation. And this is part 2 with Dr. Marschall Runge. He's a cardiologist, a researcher, and one of the most thoughtful medical leaders in the United States and around the globe. He spent a decade as Dean of the University of Michigan Medical School and CEO of Michigan Medicine, one of America's great academic health systems. And he spent his career at the intersection of being a practitioner, a doctor, a scientist, educator, and then the future of healthcare. He wrote a great book, which I recommend to everyone who's interested in how AI changes global healthcare system. It's not just about the United States. The title of the book is The Great Healthcare Disruption. So Marschall, I'm so thrilled. Welcome back.
Thank you. It's great to be on your show again.
And in our first episode together, we talked about the book and we were painting this landscape of how AI is getting implemented across the medical field. So drug discovery, use of AI in healthcare administration. Since we met on the podcast, I launched a global AI literacy study where I reviewed the state of AI literacy and AI fluency. Those are not the same things in the world and across different segments in the economy and in the society. And right now I'm focused on 4 fields. So I have small and mid-sized businesses. I have educators, mostly teachers in school. I have young people starting with the 16 to the year when they start their very first job post-university. And then I have experienced professionals aged 45 years old or older. And I am really looking for answers. What do those people and those companies use in terms of AI and robotics? What do they think? So everything is on an anonymous basis when I do my surveys. And there are some very interesting findings, which were kind of surprising for me in the course of this research. And frankly, I do this research pro bono. It will appear on the 22nd of October, and it will be disclosed in the House of Lords in Westminster in London. And today, I would love to explore another segment of AI literacy and fluency, but we are going, of course, to discuss medicine and healthcare. And I would love to understand what is happening today and what might happen, I don't know, 3 to 5 years from now. How do we educate the next generation of doctors? So, Marschall, you are aware my daughter is dying to study medicine. So she's now in the 11th grade. So next year is the IB year. And then she will hopefully pass her medical exam to enter the university. But let's just dive in and start. So how do we think about this next generation of practitioners in medicines, researchers, those who are going into pharmaceutical companies, maybe into academia, and how do we connect this world of youth with the world of technologies and AI? As you know, it's so prevalent and we are just at the start of the technology revolution in healthcare. So it will go on. Marschall, could you maybe paint an initial picture and then we will go deeper?
Yes, it's a great question. And it's just as the technology is new, how we educate learners, medical students, other clinician learners, and researchers in the use of AI and how they can benefit from it. I think we have moved beyond the initial fear that everything was going to become AI and people wouldn't have jobs because AI would be doing their jobs. But I think we're in a phase that I think could last for some years, where we view AI as a valuable assistant for people. And I'm going to speak mainly about clinical medicine. Sanjay Gupta, who's obviously a well-known person and big CNN correspondent on lots of topics, very knowledgeable guy, a neurosurgeon. He is a Michigan graduate, and he gave our medical school commencement address this year. And he said something that really resonated with me, which is what our next generation needs is not just artificial intelligence, it's authentic intelligence. And what he meant by that, which I thought was very wise, was there's a tendency. AI is so easy to use, so fast to use. And I think we should be using it. I don't think that we need to shy away and say, no, you can't use AI. I think it's a valuable partner, but you have to have some sort of baseline in which to assess the reality of what you're learning from AI. And I think so. So the questions going forward, I think for our learners are, what is that baseline? I personally think that baseline can change dramatically than what it has been for many, many years. We have both in the U.S., but also internationally. The medical school curriculum is not so different than it's been. Seen little tweaks here and there. But for example, do our students need to spend months doing anatomical or gross anatomy? I don't think so. They can learn all that from images. And is there anything valuable about the textile part of doing gross anatomy? There's really not. And likewise, is there, to take a different example, the enzymes that process drugs in the liver are really important. Does that mean they need to have memorized the Krebs cycle, which is, for your listeners, it's how these different enzymes work in different ways? And the answer is no. The answer is because that information is out there and they need to understand it. So they need a baseline understanding in all these areas so that if they don't understand anything, oftentimes AI can help explain it. I can say, well, I don't know how you came up with that answer. And it can help explain it. And then I either accept it or reject it. But I think that balance. So for example, the first year and a half of medical school in the United States now is really devoted mainly to the science of medicine with some clinical interaction. And I think, that could be shortened by half. And so what does that leave more time for? That leaves much more time for the clinical interface with patients. And I think AI can be really helpful. And I'll give you one quick example and then I'll stop droning on and on about it. But most of the patients I see today come in and they have already looked up their diagnosis. That's not a new thing. They used to look it up on WebMD or on UpToDate or on Reddit of all places or on social media. But I actually encourage them to look it up on AI because that gives them a pretty good baseline. And what I tell them, and AI has gotten good about this, about saying, I'm not a doctor. I'm providing you information. And I think that that's very helpful to patients. And it's almost the thing that's most unique about getting those answers from AI is you can put in your age, your demographics, your medications, your past medical history. You can put in whatever you want and you get a customized answer, not one that you have to read 30 pages of text to try to figure out what the answer might be. Now, the answer generally is pretty good. So I tell my patients that I think AI right now is the most valuable source of information about medical problems, the easiest to access.
And frankly, there are some fantastic models which are dedicated to medicine. I think the Elastic Engine is one of those. I mean, that's
Yes.
just fantastic. So the quality, and whenever I talk to real medical practitioners, so they are raving about the service. But, I would love to kind of, understand how medical curriculum happens. But before going there, you're mentioning that medicine is medicine, anatomy is anatomy in Switzerland or in France or in the United States. But, we are living in a world where we have a demographical crunch and some medical fields might suffer because we might get to the scarcity of human doctors and nurses. For example, in Japan, so they're using robots in healthcare, not just because, let's say, Japanese people are much more open to machines, but because they're saying to lift a person from the bed and, carry this person somewhere, nurses are not that strong to do it. So we would rather apply those machines, which sometimes look quite nice, like a gigantic teddy bear. So I've seen a couple of those. People are fine with them. So nurses are laughing at them. And but they serve a purpose because humans can't do the same job. And I'm thinking with the scarcity of doctors, first in the education, for example, in Switzerland, there are limited places to study medicine because a professor or a faculty can't accommodate that many students. I'm wondering if we have AI, can it open up for more students? Can it democratize just the access to study medicine and becoming medical practitioner? So this is the first question. And then the second question, what is the openness in those bodies designing the curriculum? Do they know a lot about AI and robotics? Are they open, or do they paint it with, let's say, rather sober colors and are afraid that something might happen with those humans occupying those jobs and teaching at the universities and medical schools? So what is your take there?
Well, first of all, you bring up a really important point when you mention Japan, because it's a good example of what is a worldwide phenomenon. And that's the mismatch of physicians and the aging population, which is a large population. It's more complicated. And the third component of that I would add is the inadequacy, particularly in the United States, of primary care. So compared to the rest of the world, we have far fewer primary care physicians per capita than any other country, any other peer country. So how do you translate having AI help with that? And first of all, I think AI, and we're doing even some pilots. We haven't selected anything, but we're doing pilots on AI as an assistant, and not only having AI be an assistant to a doctor or a nurse, but having it be assistant to students. I'll give you a great pilot that has been done at the University of Michigan. They, almost 3 years ago, started using AI. Every incoming freshman college student could have their own personal AI tutor. And the thought was they'd go out and grab, they missed the lecture, they get the lecture notes. But it rapidly evolved to using AI to improve their learning. So some people learn well by answering test questions. Other people learn well by listening or looking at slides. And so AI tested these students, found out how they learn the best, and then used that to help them really accelerate their learning. So I thought that was profound. You asked I won't say $1 million question, it's like gazillion-dollar question about how it will be accepted. So among educators, they are medical educators, and I think university educators, they're among the most change resistant. They've been doing things the same way. They don't like this idea of technology. And then they populate the boards that oversee accreditation. So whether it's the LCME, which accredits medical schools, or the ACGME, I know it sounds like letter alphabet, who accredits resident training. And they're populated by these people who want to see it the old way. And it's very bureaucratic. So I think a key success need for AI in education is going to be changing the way those certifying boards accredit medical students and accredit residents. So I think all the pieces are there. I think it's a very change-resistant area. I will say that there are some medical schools that are progressing much more rapidly than others. Sort of the bigger, more established ones tend to be the slowest movers. So maybe it's good. Maybe we'll see how smaller medical schools pilot it and how it works. But I think the potential is there to improve learning, to accelerate learning, and to be able to certify them. The last question you didn't ask me, but people do ask me, well, medical doctors have to be certified. How do we certify AI? And I don't have an answer to that, but I think AI has to be certified. So how do you certify something that has such an immense knowledge base? But so there'll be a different way to certify different AI engines. OpenAI, which you may be familiar with, is one that's only available to physicians right now. It is superb. It's a curated form of any other AI engine for medicine. So that's what I'd
you
say.
are touching on something. So I was actually hoping to hear about more openness in those institutions who are designing the programs for students of medicine. And I would like to share something with you. So obviously in my current study, this is general population, general AI literacy. And sometimes I'm always saying the silence is always a response. It's not just like lack of data or responses, which is like pity. So I fail in my survey, but sometimes that some categories don't provide answers. This is already an answer on its own. And I have those 4 areas which I'm currently looking at. And the least performing survey was the survey among educators. But it was the survey which was opened more times than any other survey. So it meant that people actively open it, and then they decided it was an active decision not to provide input. And by the way, everything is anonymous. So there is no way I can identify a person. So this is completely not possible. Even, I could say a person, a male or a female from the United States. This is it. And so teachers, educators were saying more or less, we don't want to engage. I was really communicating with leaders of multiple school organizations like Global IB. And so this system is one of the best in the world. So I'm not talking about, let's say, something which is completely deprived of resources and knowledge. And there are fantastic leaders there. But the general attitude is we don't want to ask our school to input. And in general, we are against AI. And then those are the studies about how AI deprives humans from cognitive abilities. Then you look into who was doing those studies. And those are foundations populated by people who have never studied AI. And yes, if you outsource your thinking and if you are using AI as, let's say, a substitute as a cheating machine, well, but it's your active decision to do so. It's not like you are learning with AI. And then on another side, I have young people inputting into this survey. And I'm quoting one person saying, the issue is not AI. The issue is lack of leadership on whatsoever level in schools, because we would love to learn about AI. AI is there, and our teachers behave as if it wasn't on the menu. And this is why we learn from TikTok and Instagram. Instead of, for example, learning about interesting medical platforms or some smaller AIs which are more proved for hallucinations. And so what I'm hearing from you is like more on the level of don't talk to me about it, leave me in peace. How can we change this status quo?
I think you're right, and your anonymous survey is correct. It is a leadership issue, and without strong leadership, I think it's going to take longer to implement. Now, I say it in that way because AI is not going away, and educators can hope, well, this is a flash in the pan. It's not a flash in the pan. I think maybe in our last conversation, I used this term that's been used, that we are at a Promethean moment where everything changes. And it is. It literally is. It's the biggest change in my lifetime and bigger than the internet. So I think that once there are sufficient leaders who not only embrace the idea, but embrace it for their organization, that'll gain momentum. It's like everything else. Everybody's afraid to put their toe in the water, or they don't want to put their toe in the water. But when there's enough evidence that other people are doing great things, it'll change the day. An example of that, which didn't work, was the movement from doing actual hands-on gross anatomy to using simulators and technology to get the same knowledge. That was a big push 15 years ago. Basically, the gross anatomists put a stop to it because they didn't believe in it. So it's just, I use that as a sole example to say this is not an easy issue, and it will take great leaders. And I think that they need to hear from people like you about what the benefits are and the reality that this is not going away. Fortunately, I think the leaders of my generation we're aging out. So I think I say fortunately because your listeners are younger and they'll be much more likely to find this acceptable.
And Marschall, what are like benchmark schools these days very open in terms of leadership inviting those courses in? So obviously Michigan is your school, but what else where people could find great examples and actually unscare themselves?
Well, I'll mention a few. So I would put us at the middle of the pack. I'd like to say we're leading, but we're not leading in that area. I think that there's some schools that are really developing unique curricula. So it wouldn't surprise you to know that those in California, Silicon Valley, Stanford, UCSF, I'm talking about medical schools, but there are others. For example, people know the name of Vanderbilt. Maybe it's not quite on the tip of their tongue as it is some of these other medical schools, but it's a terrific institution. And they have proven over and over again with different leaders that they're willing to take on difficult problems. They were the first institution to connect genomic DNA databases to their electronic medical records. The first. You don't hear a lot about it, but they were the first to do that. And so they were early in informatics and had some great informatics leaders. And so I think take a couple from California, take Vanderbilt. Another hotbed of technology is, of course, New York City. And I don't know exactly which schools are doing which, but there are many of those schools that now have become, many. There are two that have become tuition free, which is a huge thing in the United States on the basis of a philanthropist. And I think others, as they get philanthropy and it's tied to AI and AI-related education, they'll change. I mean, money changes a lot.
Yeah, that's very true. And on the international landscape, what are you hearing there?
Well, I don't hear as much. I have good friends in Germany but my best friend in Germany is kind of my stage of life also, so he doesn't have a real inside view to it. I know some younger people who train in the United States and are back in Europe, Germany, Switzerland, and the UK. And what I hear from these people is the change is not rapid enough to suit them.
It's interesting. Marschall, I would like to ask you about some medical professions which are on the tip of the tongue of everyone of being eliminated by AI, like radiologists. What is the real conversation there?
Well, if you'd asked 3 or 4 years ago, the radiologists were saying, we'll be out of a job. Now there are more open radiology positions, and that's not because the training positions have decreased. There are more open radiology positions today than there were 2 or 3 years ago. So the truth is it hasn't resulted in an elimination of radiology. That's one of the big ones. Another one's histopathology, anything digital. So AI is quite good at digital image analysis. But I think what has slowed it, and I'll use the example of mammography. So lots of studies in the last 18 months about how great AI is for mammography. And it gets the New York Times, Wall Street Journal, CNN, it gets everybody's attention. And these are comparisons of a radiologist interpreting a mammogram versus AI and saying that AI is better. Well, how did they define that? AI identified more abnormalities on a mammogram. I think that is a tremendous, blind eye, because what we need from AI is clinical diagnosis. And with a mammogram, maybe there's a place there that the human eye didn't find. Now, is that an early cancer or is that just a little abnormality? And none of those studies are paired with biopsies. And so I think AI is great for identifying negatives. Normal is normal. And if AI says it's normal, it's normal. But when it starts looking at lesions, we need to understand what's the clinical implication, because if half those lesions aren't anything and half the women with those lesions have to have a needle biopsy with its own risks and pain, that's not helping. So I just think the studies, a lot of this gets in the press. They don't read the study and they don't understand. And maybe they don't have a clinical background. They don't understand. It's not just what the interpretation is. It's what the clinical significance is.
Absolutely. And to learn radiology, you still need to go through all the necessary steps as today, because human brain can't just leapfrog and there isn't a pill to swallow and then out of sudden you recognize all the anomalies. So you really need to learn with all the difficulties to become a professional radiologist. And I wonder, so we kind of hope that those institutions designing curricula for universities will be more inclined to embrace AI. But what is happening in the existing medical facilities? So this is not just bringing technology in, it's bringing change management, which is probably the same as on a factory flow somewhere in an automotive company or in any other company or business embracing AI. So what is happening there? And do you see some interesting benchmarks or cases?
Well, again, you hit the nail on the head. I don't know if that's a Swiss expression or not, but you put your finger on what the critical issue is. And AI has two fundamental applications in healthcare. One is around diagnosis and therapy and algorithms. I think that's coming along. It's not coming along fast, but it's coming along. Where it has already proven value is in operations. And that is more analogous to other industries. Two examples. One is the use of ambient AI, which is the AI listens. If I'm seeing a patient, it listens. I ask the patient, is it okay if I use AI? Never had anybody say no. But it saves the clinician all the time that it takes to write a medical note, because the AI writes an excellent medical note. So that's good for the physicians. It's good for the patients. They get their note right away, and it's good for physician burnout. So because they are saved an hour or two a day of just dictating notes. But they're much more, I think, they're great examples of how AI can expedite clinical flows. And I'll give you one, and this has to do with surgery. There are several studies now done. We haven't started doing this at Michigan yet, where it watches basically every different surgeon who operates in an operating room. They know that when I finish a case, I'm done. And the person's going to go to the recovery room. When Joe is finished or Cindy is finished with the case, they're going to check all the knots and they're going to go through it again. And so it may be 20 or 30 minutes before their patient goes to the recovery room. Well, why is that important? Well, first of all, it's great for the people who are waiting. So instead of going to the desk and saying, well, when is my friend, loved one going to be in the recovery room, and hearing, well, they're working on it. The AI helps predict, well, that's going to be in 15 minutes and you'll be able to visit in 15 minutes. Or no, it's probably going to be an hour. Why don't you go grab a lunch and come back? But much more importantly, when I finish, if I'm the fast operator, when I finish the case, I contact environmental services, the people that clean the room, and say, okay, the room is going to be ready in 5 minutes. So come here. And it doesn't waste personal time, because they know they get there and they can start cleaning the room. And on the other hand, someone who's slower in making that transition, they say it doesn't notify them until 5 or 10 minutes before they need to come. And the practical importance of that is that in several studies, there's been a 15 to 20% increase in the efficiency in which operating rooms are used. So that can translate into hundreds more cases that can be done in a single operating room over a month. And so, I'm sure the same thing is being done. I just don't know personally about it in management of hospital beds and other scarce resources, imaging resources. I had to have an MRI one time, and I go down there and I'm like waiting to get my MRI. And it's for many different reasons. So if we can more efficiently utilize our scarce resources, that just like factory, I mean, that's that's an important efficiency factor that AI is bringing to healthcare, which all the different lean processes or Six Sigma have come nowhere close to what AI is.
Marshall, I would like to ask you about nurses. And,
Yes.
I was mentoring a group of doctors, and the topic was stakeholder management. So obviously, the nurse is a very important stakeholder. And I read tons of medical papers about how the role of a nurse should change and how the nurse might become this digital project manager on top of everything she or he has to do today. I am not a medical practitioner. And fortunately for me, I've been only once to a hospital when I gave birth to my daughter. So what is the reality? Can we put more to-dos on the shoulders of a nurse? Do they want it? Or should it be someone else as a role, as a cluster of jobs in the healthcare system, kind of, embracing those details on how to implement an AI workflow, or let's say AI in radiology or AI in cardiology on some floor in a hospital. So what is your thinking there? And how should we reskill those people so that they can live up to the new task and actually a completely redesigned job category?
Well, I think it's a great opportunity, and I'll come back to that in just a moment. But I will say, in my experience, both at Michigan and nationally, nurses are the most resistant about AI, and it's because they think they're going to lose their jobs. And the National Nursing Associations have taken the stance, this is bad, you lose the personal touch. But here's what I think. So we talk about, in the U.S., operating at the top of your license. And what does that mean? Well, that means if you're trained to be able to do certain kinds of patients' interactions, including procedures, you ought to be working at that level. You don't need to be doing things that are menial, kind of bookkeeping sort of things. In the United States, we have a huge shortage in nursing. Even if we expanded every nursing school, we'd still have that shortage for another 5 or 10 years. And on the, I think, greatly positive side, in the few cases, and this is only a few that I'm familiar with, when nurses find that they can really have much more time with the patient, they can have much more ability to affect that patient's outcome by their nursing care. And they don't have to do a lot of the just charting and other things that can be done by AI with AI assistance. It's a much more satisfying job. I mean, they hate doing that, just like everybody hates documentation. Medicine in the United States has come to where documentation sometimes is 20 or 25% of the time you spend. And just as with AI and ambient AI and patient encounters, a couple of years ago, I went to see my internist just for a checkup. It was the same. He's like looking back and forth, typing on you can't see my hands, typing on his keyboard. And we hardly have an interaction except sideways. With the AI assistant, we're having a conversation. And it's much more meaningful. And it's that human interaction that is so important in healthcare. So I just think it's a matter of people being able to leave their unfounded biases at the door. And again, it's sort of it's a pilot project issue. We get enough people to try it, I think they'll love it. And that is the reality so far. When I was CEO of the health system, it was a really good day if I had said 51% of people agreeing, if 52% of people agreed with my decision, and only 48% didn't agree. But with implementation of some of the AI, it's been 80%. But people have to try it. And they're medicine, I don't know about business, but medicine is very
everything is very slow to change, and people are arguing with this tacit knowledge, not the factual knowledge, but this in between, saying that it's impossible for AI to capture, and therefore we can't really automate. And I can only say that sometimes we are forced to automate because, for example, the workforce is retiring. I was in one of the AI implementations and had to automate one factory floor, and those workers, brilliant, experienced professionals, they were not capable to describe what they were doing because they were doing this for 45 years. So I had to video them and then really video to text. And then we were sitting and like, is this a right description? So this is how we came to the workflows. And then, of course, if you have workflows, everything is easier. And it was done together with them. So they understood the reason. It was kind of a process. And we had only 42 positions to describe, not like 180. Yeah. But you imagine, those terabytes of material to analyze and to transform. I assume it's similar in hospitals, but I'm always remembering what Eric Topol said. We have to kind of emphasize care in healthcare. And this is about human interaction and communication. So how is this component being emphasized in schools for nurses? So is it the same as for clinicians or is it slightly better? So what is the mood there?
Well, I think the mood has always been that it's about the patient. And for in nursing school and nursing experience, it's about they will spend more time with patients than any other healthcare provider. And that's absolutely true. And that's their mission. And similar to, I certainly concur with Eric Tobel, that our bottom line is not just our bottom line financially. It's improving health. Not just health care is an important component about that, but also improving health in general. And I think in the United States, we can do so much more around prevention. And I think AI can be very helpful with that. So I think their training is fine, maybe great. But I don't know in depth, but I don't think they've quite hit that point of incorporating that commitment to patient care with use of new technology like AI.
I would love to ask you about digital twins. And I know that your regulator is much more open to embrace those than regulators in other countries. So what is your view on them, and how well evolved is the technology, and how much are those in use? Or is it just, let's say, a real very rudimentary approximation, so we can't really run sophisticated pilots and trials with those?
Well, let me just first ask you, Anastasia, so digital twins has many different interpretations. Are you referring to its use in trying to more efficiently do clinical trials?
Absolutely. Yeah.
Okay. Well, I don't know. What I do know from my experience with pharma is that pharma is very interested in doing so. They have lots of pilots that have shown that instead of studies requiring 10,000 people, they can be done with 500 people. Really dramatic decreases. They like that, of course, because it's much less expensive and much faster. And so far, the FDA, which is the Federal Drug Administration, which gives final approval to new medications as well as new devices, has been willing to accept that. It's very controversial publicly. So this is one of those things that gets in the media. People are saying they're arguing about it in the media. People who really don't know anything about what they're arguing about. But I think the FDA is tasked with not allowing dangerous drugs to get on the market. And there are many examples of individuals in the FDA over time that actually didn't readily approve drugs that were already approved in Europe. Sometimes it made no difference. There were a few major examples of how it was good that we postponed, but people always complain, well, Europe already has that drug. So I think the fact that they're giving that signal that clinical trials can be much faster and much less complicated. And ultimately, I think that makes medications less expensive. I think it's a good thing. How far it'll go, I don't know, but I think the use of digital twins in clinical research is valuable. And I won't say it's 100% accepted, but it has been accepted.
And Marshall, I would like to ask you my last question for today. When internet has just started, there were all kind of mood swings and scenarios, and actually none of this were 100% correct. And we have a lot of Cassandras around AI today, and then we have people like Elisar Yudkowsky. So if someone builds it, everyone will die. I am simply wondering, we are in this huge transition, and we are just entering this transition. So I guess it will be 20 years. And I'm not a huge believer in the agents will take over the economy in 2 years from now. I simply don't see the readiness of legacy IT systems to allow for that, and readiness for people to accept that. I'm wondering, what is your vision for this transition period? So are you thinking in the categories of 3-5 years? Are you thinking it will be faster than we hope or are fearful about? What might happen next if you are to become a prophet now?
Well, I would put it at the 3 to 5 year mark in the United States. And the reason I say that is healthcare in the United States is much more capitalistic than it is in most other highly evolved countries like Switzerland, UK, Germany. And so it's a business here. And I think people have to accept that and accept that AI will be able to help them be more efficient in their business. However, the caveat I'll give is one that I've heard both about AI and about autonomous car vehicles. I don't know how much autonomous vehicles are making an impact in Europe. But so there is the most common autonomous vehicles are in San Francisco. They're called Waymo. And you call an Uber, and if you call Waymo, a car shows up, there's no driver. And I'll save you some of the fun details about it, but there have been 100 million miles in Waymos and no significant traffic accident, which is way better than human drivers. But prognosticators believe that the first time there's a death resulting from a Waymo, just like the first time there is a documented death caused by AI, it'll be headline news. Even though, people are dying in automobile accidents, I don't know what the number is these days, but hundreds and hundreds a day across the United States. The one with Waymo is going to make life complicated. And even if AI is saving lives, saving time, saving money, making life and health better, the one death is going to put things back. So these will happen. And the question is how much, but I think lacking those, I could see broad implementation within 5 years, maybe sooner.
Marschall, I can't thank you enough for your time, and you're really a treasure of knowledge. So I would love really to stay in touch. I'm sure you will be having another book, which I hope to review on this very podcast. That was another AI snack with Marschall Runge and Imaginary Romy and Robbie. And I was your host, Anastasia. I will see you next week. And until next time, stay curious, stay informed, stay critical, and keep snacking on AI knowledge. Thank you.
Thank you, Anastasia.